Okay, hi everybody. I'm Dr. Sherif Elghamry. I'm a consultant orthopedic surgery. I can see that we have more than 200 participants today. So I would like all of you to, I will encourage you to visit our website. And who is interested, he may apply also to our membership. Next. Today I will highlight the relation between rotator cuff tear and impingement syndrome with its most common problems and variations. Next. The factors causing rotator cuff degenerative tear are mainly, no, the previous one. Extrinsic factors causing extrinsic compression as acromial spurs or downsloping of the acromion, or they are due to intrinsic factors as degenerative microtrauma. Next. Neer classified the rotator cuff tears into traumatic tears, acute dislocation, multidirectional instability, and impingement tears, in which the impingement tears makes 95% of all. He stated that glenohumeral joint destruction with loss of the fulcrum action after old large tear can lead to rotator cuff tear arthropathy and superior migration of the head causing impingements. Next. The incidence of the types of rotator cuff tear based on 1,000 evaluated cases in our hospitals showed the presence of traumatic tear is only 7%, mostly due to fall on the outstretched hand, and multidirectional instability tears or partial tears in 2% of the cases, while the outlet impingement tears were present in 91%. Next. The anterior acromioplasty procedure for treatment of outlet impingement rotator cuff tear was described by Neer in 1983, and the repair of the tendons was done using the either simple and or a Mattis transosseous sutures. Next. Later, the anterior acromioplasty was done arthroscopically. Next. Modification was done by a measuring needle technique to measure the subacromial space and monitor the decompression using surgical standards and calculated decompression targets. Next. The rotator cuff tear was arthroscopic or subacromial decompression is done using suture anchors, mainly single row or double row techniques. Next. Or arthroscopic transosseous rotator cuff repair, mainly using the giant needle technique. Next. And the tailor stitch arthroscopic transosseous rotator cuff repair. Next. The considerations for arthroscopic subacromial decompression before doing the rotator cuff repair. Next. Do we total, partial, or no resection of the Coraco humeral ligament with a rotator cuff tear? This are the considerations. The controversies of the intervention range from recommendation of resection of the upper 1/3 of the ligament to complete removal or only detaching the ligament from the acromion. And some recommend no intervention in general or only in cases of massive rotator cuff tears. We monitored during arthroscopic decompression that by cutting or detaching the ligament from its acromial insertion at the subacromial space will increase 2 to 3 millimeters. And we observed in most decompression revision cases that the ligament is grown again to anterior acromion. So we described that as an indirect lengthening of the ligament. Next. In cases of frozen shoulder, superior subluxation may be present due to intra-articular adhesions. So the considerations are taken to first release the adhesions from the glenohumeral joint, then evaluate the subacromial space to determine the amount of bone to be resected from the anterior acromion for decompression if needed. Next. The large old rotator cuff tears may cause superior subluxation with intra-articular adhesion. In treating these cases, considerations has to be made to release the adhesions and mobilize the rotator cuff. Then do a tendon complete or partial repair, and finally measure or evaluate the space for subacromial decompression. If no repair can be made and reverse total shoulder is not possible, so you do subacromial decompression anyway in order to minimize the head contacting the acromion, which may cause the pain, and also to lessen the possibility of arthropathy complications. Next. Calcium deposits in the supraspinatus tendon can lead to thickening of the tendon and narrowing of the subacromial space, causing impingement, which may need arthroscopic intervention. So consideration has to be made to do arthroscopic calcium removal with or without repair. Then measure or evaluate the subacromial space and do the compression only if still have a narrowing. Next. Prominent greater tuberosity causing impingement in Erb's palsy is treated by arthroscopic resection of the supraspinatus tendon from its insertion on the greater tuberosity, followed by removing of the head overriding bone from the tuberosity with an acrominizer. Then reinsert the tendon using transosseous sutures. A subacromial decompression is done if needed. Next. In case of prominent greater tuberosity due to malunited or non-united tuberosity fracture, malunited surgical neck fracture, and in case of low head implantation. Treatment is done by arthroscopic resection of the supraspinatus from the acromion and removal of the head overriding bone, followed by transosseous reinsertion of the tendon and subacromial decompression if the space between the anterior acromion and the tendon is less than 12 millimeters. Next. Instability impingement dynamic superior migration due to contraction of the deltoid can cause a narrowing and impingement. Here, treatment is done by first stabilizing the glenohumeral joint through the inferior capsular shift or other arthroscopic similar procedures, followed by measuring the subacromial space to do a decompression anterior acromioplasty if needed. Next. Is subacromial decompression indicated to relieve pain in massive irreparable rotator cuff tears? Rookwood suggested that the decompression is the only treatment needed for all types of rotator cuff tears, but functional problems and some movement pain were the disadvantages recorded. Whether Neer proposed the open decompression as a pain-reducing procedure for irreparable massive rotator cuff tears. Reverse total shoulder is now the treatment of choice for irreparable rotator cuff tears, but patients refusing reverse total shoulder are offered the arthroscopic subacromial decompression as a possible pain relieving option. Next. The take-home message is a thorough investigation should be made to localize the real cause of impingement, especially in non-outlet impingement. Arthroscopic measurement of the space between the anterior acromion and the rotator cuff has to be made. In cases of outlet impingement tear, the repair of the torn rotator cuff is done after arthroscopic subacromial decompression. In case of non-outlet impingement, first treat the inferior or other causes of subacromial space, narrowing before doing an anterior acromioplasty. Thank you very much.